An AI tells a patient in a diabetic emergency to book an appointment in 2 days' time. That finding, published in one of the world's top medical journals, went viral recently. But what if the study was measuring the wrong thing entirely? Today, we talk to the researchers who pushed back, and what they found might surprise you. AI health tools are now being used by millions of people. And right now, scientists are in a heated debate about whether we even know how to test if they're safe. Today's episode is about that debate and why getting it right matters for all of us. Enjoy. Hello and welcome to Pulse Amplify, where we sit down with the leaders and changemakers shaping the future of healthcare. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your other host, George Marcellus.
A recent paper published in Nature Medicine sent shockwaves through the health AI world. Researchers from Mount Sinai tested ChatGPT Health, OpenAI's consumer-facing health tool, and found it under-triaged more than half of emergency cases. Half. Now, that headline spread fast. LinkedIn was flooded. I think it still is. Actually, my feed still is flooded with this stuff. News outlets picked it up all around the world. And it left people questioning the efficacy of this newly released tool and whether AI should even be used in this way at all. But here's the thing about science. A headline, it's never the whole story. A team from Macquarie University's Centre for Health Informatics at the Australian Institute of Health Innovation read that paper and said, wait a moment. So David Fraile Navarro, Farah Maghrabi and Enrico Cuera, they ran their own experiments across 5 frontier AI models over 1,000 trials, and they came to a very different conclusion. Their argument isn't that AI triage is safe, it's that the original study may have actually been measuring the wrong thing entirely. So today's conversation is about how we test AI in healthcare, why the method matters just as much as the result, and what we actually need to know before these tools reach patients at scale. So today we are sitting down with one of the authors, David Fraile Navarro. David, you have been here before. I think you're the first person to have a second showing on Pulse Pod. So welcome back to the studio.
Thanks for inviting me. My pleasure to be here. I think it's an important issue to discuss and to bring to the audience. Yeah.
Yep, fully agree. Great to have you back.
Okay, so the Nature Medicine paper dropped and it got huge traction, as I said in the intro. Media covered it all over the place. The altmetric score got a 735. And for those unfamiliar with the altmetric score, it's basically a measure of online attention a research paper has received. Now, usually most research papers get like single digits. Anything over 100 is considered significant. Well, this paper got 735. So, David, when you and the team at Macquarie read it, what was your reaction when you first read this article?
Well, first of all, the reaction was one of a surprise. Originally, I was thinking how OpenAI has released such a bad product out in the public. I wasn't questioning that AI triage can go wrong or that there are issues with using AIs for these sort of high-stakes scenarios. I was a bit surprised in the sense that when I've been interacting with most of these AI tools, they tend to always err on the side of over-caution. They prefer you always go see the doctor no matter what, to be safer. So I was a bit surprised on this under-triage of the 2 cases specifically. The other thing that became very obvious is that the way that the media came to it, half the time the AI tool was wrong, and the interpretation is much more nuanced than that. So I think that's not the author's fault. That's more on how it has been received. It basically fell in interest scenarios, but most of the others were triaged correctly. So the authors themselves give a different interpretation.
Your group's not known for being AI apologists. I mean, you've done a lot of evaluations of AI. You don't argue the fact that AI triage safety really matters. So the fact that there's a couple of blatant errors that were pointed out, is that what triggered you, or is there more to it that we really need to evaluate these differently?
Yeah, so that's the point. When I saw the errors, I went to the methods to see what exactly they were testing in this paper. and this very specific structure that they use to test the AI model. So when we test large language models and AI, the main problem that we have is these tools don't always give you exactly the same results. So that gives us researchers a problem on how to evaluate. And basically, they try to recreate a medical exam question. It was very structured. It was a clinical vignette. There were some specific constraints like you should only rely on the information provided here, give us a confidence interval on your answer, and then you need to pick between A, B, C, or D. And then on top of that, then there was the actual clinical test.
So it was like an exam format then. So it was like, here's the information, and AI, you've got all these constraints wrapped around you, and you have to give us a multi-choice answer.
Exactly. And more, we are finding that when you are testing an AI, the format you actually use can influence the answer. It's not only the raw content, but how you structure it, how the interaction itself is presented to this AI will bias the result one way or another. And more than that, even if you think of the actual task of triaging patients, we need to question when someone is presenting to a chatbot and asking for symptoms, will they do that? Will they provide a clinical vignette or their own self, very structured with 4 triage options and ask for an answer? Or will the interaction don't resemble at all to that? Because that was my other main concern, not only the formatting issue and the exam-like structure is if a patient actually go and ask ChatGPT Health, it won't resemble at all like that. And that's a bigger underlying principle when we do research is we need to try to approximate as much as possible as...
That's a very important point. Patients don't talk in clinical vignettes. They talk in simple languages. And I guess that's always been one of the arguments why the doctor needs to stay in the loop, because the clinician's role is to get a proper history from the patient. That often requires us to ask multiple questions. One of the first things I worked on when I first got involved with health informatics was an online history taking tool. And it's really hard because you can really go down rabbit holes and a whole bunch of things. The key thing here, of course, is that we've seen previous studies which use, for example, New England Journal of Medicine vignettes, which are very structured. So they give you all the information you need because they're designed to be published in New England Journal of Medicine. You looked at it a different way. You looked at how patients would interact with this chatbot. What were the primary differences in the way you evaluated the questions versus the questions they assigned in the article?
So I think that's a very good difference is when you are testing an AI, you need to be very clear on what you are actually testing the AI for. One thing is you want to test the AI clinical knowledge, and that can be an objective on its own. It's like how much knowledge this AI on diagnosing, on triaging, on very specific vignettes, clinical scenarios that we use to evaluate clinicians, how good, how bad it is, right? So that's a very specific, narrow objective that you want to test the AI for. Then there is this broader question, is AI any good at triaging patients? It's connected because the underlying knowledge is all the same, but the actual answer that you will get from one and another will differ a lot. An AI can have a perfect encyclopedic knowledge and still fail at triage. An AI can have a much more limited knowledge base and have a bunch of algorithms and guardrails built in and perhaps being a much more safer for triage. So it's important to clarify what we are testing and what are we testing for. There has been a lot of debate on the use of things like the USMLE exam to test AI, because at the end of the day, if we are just measuring memorization, probably the AI will memorize much better than us.
Yes, you'd hope so.
Yeah. But if we are testing something much more high-stakes scenarios, such as triaging patients and consumer-facing tools such as ChatGPT Health, getting the format right is very important because no one is going to input those vignettes, neither clinicians or patients, consumers that are using the tool. So that's where it's very important to try to mimic as much as possible what the consumer will input.
I'm on the board of Asthma Australia, David, and one of the most striking findings in your paper was this asthma result. So the original study found massive under-triage for asthma emergencies, but you found something very different. So can you walk us through what you found?
There was an under-triage of asthma cases. Some of the data were struggling, breathing, and the actual oxygen value. Some others wasn't that clear. We found that some AIs were still not triaging the case correctly. Some of them were actually improving a lot. And one of the things that actually helped was removing this forced decision between the 4 triage categories that the initial authors were asking. Basically, they were saying, you need to go to emergency now, you need to see a doctor next day, next few hours, the next week, or this is not an emergency, this is something you can manage. By forcing this sort of discrete choice, it was actually pointing the models towards more unsafe or under-triaging the condition.
Yep.
If you remove that condition, which, to be fair, most people will interact with these models, it won't be asking A, B, C, D, what I do.
No, they're going to say, this is what's happening to my kid or to me. What should I be doing now?
So when we remove those constraints that the original study enforcing, the model triaged much better. It wasn't perfect. Some cases were under triage or weren't triaged correctly. So it can be an issue with safety with this model and using them for triage purposes, but definitely it was an improvement on what they did.
One of my favorite TV shows was the show called House. And Dr. House is known to be a grumpy old doctor, but he was very good at diagnosis and triage. And one of his famous comments is that patients lie. Now, patients don't necessarily lie, but they may not be able to give information in a way a clinician would expect. And in an asthma scenario, it's often the observations are much more important than the history. Do you think we need to add functionality, multimodal functionality into these triage tools? Because if someone's got a pulse oximetry of 80, irrespective of what they tell you, you're going to have to respond differently. It seems that just using a chatbot just doesn't have enough acuity to pick up things that patients aren't telling us.
Yeah, that's correct. One of the limitations of most of the current AI models is just plain writing text or through voice. There is very limited nuance on other clinical cues that you could have as a clinician triaging a patient. Definitely there's room for that. I also think that triage itself is a dialogue. It's a conversation between the patient and the doctor. And that's actually also something that AIs do quite well, is that most of the time, or at least in my experience, I almost never get what I want from a single interaction. I need to have a bit of back and forth with the AI. What the author says is, look, patients might report the symptoms worse, and that's completely fair, and that can be the case. But there is also this dynamic with AIs that they ask for clarifications. There is follow-up questions. I think that would be, to me, the more interesting study that I would like to run. And it's, okay, let's put them in a real triage situation. It won't be a single vignette, a single case, natural or not. It will be back and forth between the AI and the person. And then we can really tell if there are nuances missing or there is clinical information that is apparent to a person that the AI is not capturing. I think that's important too.
Well, time for a quick break. And when we return, we'll be discussing with David how much information patients share with AI, the value of a good prompt or 10, and David will give us his opinion on whether it is safe to use AI for triage at all. All that and more right after this break. Yeah. One of the things that we've discussed it before, David, we know there's research dating back to the 1960s that people will actually tell an AI chatbot more information about themselves for a whole bunch of reasons. And yet the authors of this original paper said that in real life, patients give less information than necessarily you get from the prompts. So they predicted that performance in the real world would actually be worse, not better. So how do you respond to that?
I think that's an over-assumption that they are making. Yeah, it's true the patient won't give perfect information. That's 100% accurate, but the chatbot also has this opportunity to refine the answer. It never gets the answer at the first. If we can put back this to the clinicians themselves, if you get a call from an emergency department or you are triaging someone over the phone, do you get the correct triage in the first interaction, or do you need to go through a few minutes until you get an answer? As you said, there is new research that some people in some situations actually are more open with the AI, so that can be true. The other thing is that, yes, the person might give less information or might not have this opportunity to refine as accurate as we would want or as a clinician, but the AI might also decide to be overcautious with this person. There might be this element that, okay, I'm not having a clear picture. Perhaps I'm not saying this patient or this person to stay at home. We're saying, go see a doctor.
Look, I reflect back on the original ELISA program, which is where this all started back 40 or so years ago. And what it did, of course, it kept on reiterating the question. So the reality is you don't ask a patient what's wrong with you and then write a script. It's a lot more complex than that. You looked at 5 different models. Did they all have similar challenges that poor prompting caused poor response? That's something that they've been talking about in AI for many years, yeah? It's the prompt that matters, not so much the AI. Where do you see classic differences between the various models?
So there was some differences. So we had to rely on testing the default vanilla ChatGPT and test other commercial AIs, Gemini, Claude, etc. The effects that we saw on the under-triage, it was more marked in ChatGPT models. I think Claude ones were not failing the triage, at least in the asthma scenario, as much as the ChatGPT ones. And then for Gemini, there was improvement in some of them. Gemini Flash was improving quite a lot, and Gemini Pro was more flat. Answering your questions, yes. The effects and the variability we could see affecting across several AIs and several providers. Then again, there is a bit of variability between them. They are not all built the same. They haven't seen the same train data or the same guardrails and so on. So yeah, a bit of both.
And the conclusion of your research, does that mean that these systems actually are safe for health triage?
No, I don't think we can say that. We will need to test much more. And that was my main criticism. We will need to test them under real conditions. In AI research, it's becoming more difficult to put these models under examination because they pick up cues, they pick up that this is a test environment. So we need to be very good and very careful on designing our experiments. And that's what we are trying to push here more than anything is say, look, AI triage is an important area. We need to study it. But when we study it, we need to be very thorough. We need to simulate, replicate real world scenarios as much as possible. And then, yes, if they are bad at it, we need to say it out loud.
Yes. Well, then how far away are we from those evaluations, that methodology that we can apply? Because we really need these evaluations that actually reflect how real people use these tools. And like we need them yesterday. 230 million people are using ChatGPT every week for health-related things.
It's a very, very fast-moving space. Now that we have advanced models, reasoning, the task itself becomes more difficult because the interaction between the user and the AI, first of all, is not a single question most of the times. Second, it introduces a lot of disruption elements that can change in one way or another. So what we need to do as researchers, we need to bench the medical benchmarks because a lot of researchers are still in this old paradigm that let's throw questions and calculate accuracy. We need to be much more thorough, generate scenarios, generate simulations, multi-turn conversations. We need to be creative. Some of the AI labs are doing very creative forms of benchmarks, like putting the AI in charge of a vending machine and see if it can make money or not. So I think we need to design those sort of scenarios for healthcare. Don't think of the AI in isolation. If I throw an AI agent in that process and let it run, what will happen? Where it fails, where it does it right, where I need to build another guardrail to avoid it going where I don't want. So yes, we are in the process, and that's some of the research we are trying to do, is trying to build better evaluation methods.
So we often say from a clinician's perspective that you need to keep the clinician in the loop. And some people would argue that the clinician in the loop is really the clinician's way of trying to protect their jobs. If we're going to scale these sort of things, and obviously the clinicians can't be involved in all the loops, is there a role here for agentic AI where the agent takes a history, develops a vignette, that vignette gets delivered to the system? Do we need to look at a more progressive model rather than a one-shot, type in your symptoms into a chatbot and here comes the answer?
Yes, I think what we are going to see more and more is orchestration of AI agents, of different tasks, different sorts of constraints. And one AI does the triage, another AI will judge the triage. And yes, I think that's still a role for the clinician. I'm not saying we are disappearing, but I think it's a matter of using the human factor and the expert in an intelligent way. What we don't want either is some burnout clinician sitting in a room and just clicking accept, because that has risk as well. So.
Yeah.
And I guess the other perspective we need to also take into account, and this is some of the work that's been done over there at the Australian Institute of Health Innovation, is that sometimes doctors also get it wrong. I mean, it's not like doctors have 100% accuracy rate either.
I think that's another fair comment. Triage, as well as diagnosis, as well as other things, is one of those fields that there isn't a 100% correct decision. The triage on one person at one point in time can change very quickly, can change in 5 minutes, can be missing something that became apparent later. So we are always moving in this sort of uncertainty space with this sort of scenarios and tools. So it's important to acknowledge that and acknowledge as well that we want the AIs to err in the safe of the space. I prefer over triage than under triage for my AIs, but I agree that there is a certain degree of randomness and uncertainty with triage that won't be possible to supply completely.
So we shouldn't be naive about the risks of AI in healthcare. So what do you think are the real safety concerns that we should be focusing on?
Well, I think there are a lot of unexplored, undisclosed use of AI, both by clinicians and by patients. We need to start having more open conversations of integrating AI advice, and we need to start having these honest conversations with doctors, patients, and AIs on what is our role, what is that the AI brings to the table. It could be that it needs interpretation. It could be that it's not 100% correct or 100% sure. But I think we will move more into this space that AI will be another voice that we will take into account when we are dealing with our health. And I think doctors need to keep up and they need to start understanding how to use these tools, where they fail, but also we need honest conversations on how they can also improve and help us detect things that sometimes medicine misses or the healthcare system is not catching up well.
We've talked about health literacy and digital literacy and now AI literacy. So we have obviously multiple education points and discussion. I think the important thing is discussion here. So for your advice right now, if I'm a patient, I've seen this study and I'm worried about AI, what should I know about your study that's going to change my thoughts or allow me to reflect better on how I should be using AI in the future?
Yeah, I think if you are a patient right now requiring triage, you don't want to be triaged by an AI. I think that the message here hasn't changed. What you need to know when interacting with AIs is AIs will get as good, as accurate, and as thorough and informative your input to them is. So if you are expecting to know what to do with your health with just a single sentence, that won't work. It won't work for AIs or it won't work for clinicians. So I think patients are fair to explore this use, AI tools, and see what value they can gain from it. I think it's always wise to still, when in doubt or when taking health decisions, to consult with a health professional. And yes, for sure, bring your AI summary to the consultation and discuss with the doctor.
It's interesting. When you look at some of the literature around patient satisfaction with doctors, it's often the doctors who have longer conversations who get the higher satisfaction rating. So again, comes back down to a discussion between a doctor and a patient. If you go to a doctor and the first question he asks you is what's wrong, and then he gives you a script and throws you out of the room, you don't usually walk away very happy. So it reflects back on that.
David, thank you so much for coming on the show and representing Farah and Enrico as well. I think this is a really important conversation. I agree with you. The science of how we test AI in healthcare is just as important as the AI itself. And I think the conversation we've had here today is a reminder that those headline results, they're really only as good as the methodology behind it. And whether we are researchers, clinicians, executives, patients, we all need to be across this. So thank you and the team for also this rapid turnaround and congratulations on the article's success as well in terms of its virality across the healthcare system globally as well. So well done.
I think the other thing we probably need to also focus on is journalist education, because journalists take some of these stories and turn them into sensationalist stories that don't really make sense. We've seen a lot of sensationalist press over the last week or so, but I think we have a role to play in making sure that our fellow journalists are much more open about this discussion.
Thank you, and thanks for having me.
Thank Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by myself, with audio engineering by Ivan Jurek of Octopod Productions. Thanks to Emily Mara, co-founder and publisher of Pulse IT News, for all of her support. And big thanks to everyone for listening. Please make sure you subscribe, follow and rate us wherever you get your podcasts. And of course, do not forget that you can visit pulseit.news to sign up for the e-newsletter and explore Pulse IT's massive digital archive. Send any feedback or topic suggestions to pulsepod@pulseit.news. George and I always love to hear from you.